Hope I'm audible and visible. If so, just give me a thumbs up. I hope I am. Okay. Hello, Moin. Yeah, we'll be starting the live course soon. Ankit, just Rahul ka just give us some few days. Like post holy, definitely will announce it. Hello, Charlotte. I hope I'm audible and visible. If so, just say hi, guys.
Hope I'm audible and visible.
I'm able to hear myself. Fine, great. So what you're going to do here is we are going to discuss about the recalls which happened in the recent exam, right? I'm sure you must have gone through the exam, you must have gone through the recalls. What you're going to do is we're just going to take care of a little bit of keywords. What are the keywords which will help us to come to arrive to a diagnosis? That's the first half of the thing, and definitely we'll read a little bit more aligned with the other products as well. Fine. Okay. Vaibhav Trivedi, like the languages shouldn't be a problem here, right? So we'll make sure that you will have the content in the way you can understand. That's our primary motive. We have both live classes as well as we have recorded lectures. So we'll complement it definitely for you guys. Fine. Okay. Great. Smriti, like I said, give us a week's time. Definitely post Holi, we'll definitely announce that. Fine. So going forward, let's go and discuss. So the first is this, like I want you guys to comment on the answer. It's a very simple question. I've kind of given a stem to everything because I just don't want to have a very small question and empty thing spaces there. A 35-year-old person came with fatigue and weakness. Maybe some of the guys said there were plus or minus history of DIC. Was there history of DIC? And the peripheral smear show the below finding. Which of the following is the most likely genetic change associated with the disease, right? Like I said, I want you guys to look for the pointers here. The pointer here is the structure. I'll just zoom this, guys. What is the structure? Can you guys name the structure? It's a classical finding, right? We had seen them multiple times before as well as a classical OR rod, right? So the classical OR rod here, and OR rod is diagnostic of only one disease. What's OR rod diagnostic of? I'm sure you guys know it. OR rod is diagnostic of here AML, right? Acute myeloid leukemia. So just like I said, to go something related to that, an OR rod finding is nothing but these are nothing but acidophilic granules, right? They are nothing but acidophilic granules. These are granules seen inside the neutrophil. When it becomes neoplastic, they are going to form or rod-like structures. That's all. Whenever you see OR rod, let's say DIC is present or not present, doesn't matter. For me, an OR rod present, my diagnosis is AML. Amongst this 922, where do you see this translocation? The classical findings seen in chronic myeloid leukemia, right? I can see them in ALL and very rarely in AML, but I'm not going to jump to the first as that translocation, right? Translocation 1114 is seen in mantle, right? The simple way to remember like this: mantle 1120, 1114, and 1418 is seen in follicular lymphoma, right? The only thing of these options which is diagnostic of an acute myeloid leukemia is translocation 1517, right? So there's one more name for acute myeloid leukemia translocation 1517, which is APML. APML is very, very characteristic. It's very unique that I do not want a blast percentage of 20% to diagnose that, right? That's one of the exceptions for the blast crisis, fine? Okay. Now, next question. There are quite a few of the questions which are easy. How did you guys feel the exam, at least with respect to pathology? I felt quite a few of these questions were doable. If you have read carefully for the last 6 to 8 months, you must have definitely at least cracked this exam, this pathology exam at least, fine. Okay, the very, very simple question. Again, the keywords are more important. One is age, a 44-year-old person, and most importantly, having generalized lymphadenopathy, everything. Peripheral smear shows classical finding of lymphocytosis and smart cells. Now tell me the diagnosis. Quite a few students said that this answer could be why not it's a biopsy, why not a bone marrow examination. I'm just going to tell you why it is not a bone marrow examination or why it's not a lymph node biopsy, right? Smart cells, lymphocytosis, there's only one diagnosis for me, which is CLL, right? Chronic lymphoid leukemia. That's the only thing which is diagnostic for any of whenever you have this history, right? Now it's a leukemia, right? So use this diagnostic algorithm for any leukemia, what you're going to see from now on, right? Whenever I see leukemia, first and the foremost thing for me is peripheral smear and peripheral blood. If in the peripheral blood I have enough number of cells, let's say enough number of blasts, or let's assume there is enough number of any abnormal cells, right? Immediately I'm going to go to flow cytometry for almost every leukemia except CML. For CML, you go to directly to genetic analysis, be it your FISH or be it a PCR, because in CML, flow cytometry will not help, right? So CML go for genetic analysis, and for every other leukemia, it's going to be flow cytometry. Only when I don't have enough diagnostic point, let's say the blast percentage was very less in the peripheral smear, then only I'm going to go for. If there's less number of blasts in the peripheral smear, then I'll go for bone marrow examination, or we are going to go for a biopsy, right? Before that, I don't go for a bone marrow examination because bone marrow is very, very invasive. I'm sure some of you might have seen bone marrow examinations being done. It's very, very invasive procedure. I don't go for that, right? It's blood and directly flow cytometry, be it acute lymphoid leukemia, acute myeloid leukemia, chronic lymphoid leukemia. Only for CML, I prefer genetics. I don't do flow cytometry, right? So the diagnosis here, answer here is, like Aryan said, it's B. It's flow cytometry. Lymph node biopsy is not needed for CLL diagnosis. If I know it's leukemia, I'm going to look for the blood. I'm not going to look for the lymph node. Yes, I do have findings in lymph node because it's CLL bar SLL, but I'm not going to look for that, right? Bone marrow examination might be required for prognosis, not for diagnosis, obviously. And genetic analysis again for prognosis, not for diagnosis, right? It's a very simple question. Flow cytometry, diagnostic of chronic lymphoid leukemia is fine. Great. Okay, next one. This also is it's very, very simple, right? Like I said, this time at least pathology was extremely simple and extremely doable. It's a very classical finding. We have seen this multiple times before as well. It's a classical find of image of a Burkitt's blast. 7-year-old, one of the lymphoma, there are only two lymphomas which can happen in children. One is ALL, other one is Burkitt's. That's why in previously we had kept Burkitt also as a group of ALL because only these two can happen in children. And you have a classical finding of swelling in the jaw, and bone marrow examination has cytopenias, right? Everything here is perfect. Cytopenias, bone marrow examination shows this below finding. That's diagnostic of your only 1%, which is Burkitt's leukemia, right? Gagan is right. So my diagnosis here is Burkitt's lymphoma, or I can say it's in the bone marrow, so I can call it Burkitt's leukemia. Fine. Just let's try to extrapolate this, right? Okay, now I want your guest input here. We're going to learn an amazing concept with your help. Fine. Can anyone comment on what is the stain for fat? A simple stain for fat. A simple stain for fat. So, Umidip, tell me what you're not understanding. I'll explain in Hindi. A simple stain for fat. Fat stain is nothing but your Sudan black and oil redo, right? So, can I write SBB is a stain for fat? SBB is a stain for fat, right? So, next one. When I look at this microscopic image, can I call all these tiny, tiny vacuoles as fat vacuoles? I'll come to that, Aryan, right? Piyush, you're right. Oil redo or SBB, both of them are stain for fat, right? These are nothing but fat vacuoles, right? So in general, SBB is a stain for myeloid lineage. But here I'm having a lymphoid blast. It's a lymphoma. I'm having a lymphoid blast where it's positive for SBB. So that's an exception. Remember this. Burkitt's lymphoma, it's a lymphoma, but it's positive for marker SBB, which is generally seen in myeloid lineage, right? That's one characteristic finding here. Fine. Second, this is also PAS negative. Again, it's a lymphoid blast. Lymphoid blasts are ideally positive for PAS. There's a lymphoid blast which is negative for PAS. Again, that also is a very, very characteristic finding here. Fine. Okay. Now we will go to Aryan's question of how do I differentiate this from a MOT cell? The first thing, MOT cell is immunoglobulin deposit, right? MOT cell will not be clear and white in color. MOT cell have a bluish hue. And in MOT cell, the nucleus will be smaller and the cytoplasm will be huge. But there's a blast. Blast will always have a high NC ratio. Those are 2 points how we can differentiate a MOT cell from this cell. Fine. I hope that clears it out, Aryan. Fine. Okay. Next. Again, a very, very classical finding here. I will go faster and quick and finish it soon. 47-year-old post-renal transplant investigated for routine follow-up. Urine examination shows classical outside inclusions. We have only one person with an outside inclusion, right? Two ideally. If it's outside nucleus, I look for Hodgkin's lymphoma or I look for CMV. If at all I have to differentiate your RS cell from microscopy from the CMV, RS cell, the nucleoli of the RS cell will be pink in color. In a CMV, the inclusion is in blue, intranuclear blue inclusion. That's one classical difference between RS cell and a CMV, right? Okay. So here it's a classical finding of a CMV. The outside inclusion is diagnostic of CMV. Just since we are in post-renal transplant, BK virus is one of the commonest virus which I want you to remember, right? Let me ask one more PYQ, previous year question. What do you think is the classical cell's name? What you see in urine examination in case of an BK virus? I have a very classical named cell. What do you think is the name of the cell? We have a named cell for a BK virus. You must have heard them, maybe in surgery or somewhere. We call them decoy cells, right? So these are called as decoy cells, right? This might come in an exam. Remember that you have something called as decoy cells. Okay, decoy cells are diagnostic of your polyomavirus, but again it's a virus, right? It's again a virus. So decoy cells are nothing but it's an inclusion virus, that's all, right? So when you see a urine examination, if you decoy cells are not multinucleated, it's single intranuclear homogeneous inclusion, fine. So if we see an homogeneous inclusion, that's diagnostic of it, fine. Okay. PK virus full form, I'm really not sure of. I'll definitely come back to you for this. I'll ask Mamta Java to talk about the BK virus, the virology part. She'll definitely talk about that, right? These are urine examination findings. In urine examination, you see this inclusion. That's a classical finding of an intranuclear homogeneous inclusion, diagnostic of an BK virus, right? It's a polymer group. I remember the name. I forgot it, right? I'll ask Mamta to fill it up soon, right? Next, it's a very, very simple question. 55-year-old lump in the breast on investigation, which of the following would have been a good prognostic sign if they are positive, right? So you must have definitely remembered luminal A, luminal B, HER2 enriched, and your triple negative cancer, right? Of these four, which you think is has the best prognosis, luminal A or luminal B or HER2 enriched or your triple negative, which has the best prognosis? It's fine. You can comment. If you're wrong, it's completely fine. We'll just just gonna learn. We'll make up for all of your mistakes, right? Luminal A has the best prognosis, right? Luminal A has the best prognosis for sure, right? Perfect. So if you remember luminal A is actually an triple negative cancer, ER positive, PR positive, and HER2. Sorry, luminal A is HER2 negative cancer, right? Triple negative will be the basal type, which is the worst prognosis. Luminal A is ER positive, PR positive. Whenever estrogen receptor is positive, definitely it has a good prognostic factor, because when ER is positive, I can give serum SERMs, tamoxifen as a role of diagnosis, right? Okay, I'm going to ask you a question. We can think through it and then answer to me. This was asked by one of the students, and it is a very, very good question. Apparently, it was asked in Viva. If you don't know, ping me later on in Instagram or WhatsApp. I'll definitely give you the answer, right? Now, what is the role of PR here? Do you have any drugs which targets progesterone? You know SERMs, right? Serum estrogen receptor modulators. Is there any serum progesterone receptor modulators? We don't know, right? So why is this PR required at all? If PR is negative and ER is positive, good or bad? So what is the use of understanding the importance of progesterone receptor in a breast cancer? This is a question for you guys. Read whenever it's possible. I hope they won't ask in the exam. Read whenever it's possible. Just it's an initiating point, right? See, you have to go beyond the exams. You have to learn beyond the exams. That's very, very important. Just answer this question whenever it's possible. Fine. We go next one. So it's an histology image. Kidney is something which you've been seeing quite some time, right? If you remember last year, there was a question on your islets of Langerhans. So the histology, they're making sure they'll ask one point. I have the WhatsApp group and Telegram group. We'll make sure before INICET, we'll see every histology slide one by one, right? The classical image of an glomerulus. There's a glomerulus, that's a glomerulus, that's a glomerulus. So all these are glomeruli. Okay. The answer is simple. That's a glomeruli. Last year it was islets, which was asked. Lymph Hassel's corpuscles also was asked previously, and lymph node. I'm sure you know the cortex and medulla and all the um, uh, follicles in the cortex. That's easily diagnostic. Like I said, I'll keep on posting questions till your INICET in the Telegram groups so that you get used to all the normal histological structures as well. Fine. Okay, great. The next. I want help from you guys, right? So kindly fill up this question, because students told me some options which doesn't make sense for me at least. What is the question exactly? Can anyone fill up this question? Was this the right question? Which of the following is a true statement regarding the relative risk of Mendelian inheritance? Is this correct? Yes, no. How- Is this question correct, by the way? If this question is correct, the options which are told to me were this. Because for me, it doesn't make much of sense here. Which of the following are true regarding relative risk of an Mendelian inheritance? And two-thirds of autosomal dominant, one-third of autosomal recessive, one-tenth of Y-linked, and one-fifth of X-linked. These were the options given for me. Were these the options, or was there any change here? Because there's a very it doesn't fit anywhere, because I'll tell you the relative risk, right? So relative risk happens like this. You must have read about relative risk. Relative risk is nothing but when the offspring, how much percentage will be offspring? Okay, Divyansh, it was prevalence of the disease. Okay, fine. So was it a prevalence of the disease? or the relative risk? Because prevalence is an extremely weird question, because prevalence of the disease varies lots based on the group which I'm studying. Like if you take cystic fibrosis, it's more common in the Caucasian group. When I take a prevalence of the disease in that group, it varies a lot. Relative risk, this doesn't make sense at all, right? I'll give you an overall idea of what happens, because I'm not sure if this is the exact thing which is came in your exam. Autosomal dominant is obviously the most common disease. Okay, Piyush. Okay. Of the groups, autosomal dominant is the most common disease. When I say disease, it has to be symptomatic, right? Achondroplasia is a symptomatic disorder. They don't have a carrier state. On the other hand, autosomal recessive, the number of mutations are extremely high. Mutations are very common in autosomal recessive. Some of us might still have the mutation, right? I might be a trait. It is said that 1 in 50 people have a single gene disorder. 1 in 50, that is very huge, right? At least one of the disease mutations they'll have. It's very common mutation, but they will be in recessive state, so they don't manifest at all, right? It's 1 in 50 is the incidence of quite a few autosomal recessive disorders carrier state. So the mutation is very, very common in autosomal recessive disorder. And Y-linked is an extremely rare disease. X-linked is okay. X-linked is a decent one. X-linked recessive is definitely decent. Dominant is again a very, very rare disease, right? Okay. So this is the overall thing. If it's prevalence, I will not be able to give a standard prevalence because it's a genetic disorder. It varies from place to place. Let's take sickle cell anemia. If I'm going to take sickle cell anemia prevalence, in Africa it is 1 in 8. In northeastern eastern states, it's very common. In southern states, it's very, very rare. So it's very, very impossible for me to tell the prevalence unless there is some regional association given. So I hope they will change this question. There's one more question which is like this, which didn't fit into any of the thing. We'll definitely see that also soon, right? Okay, this was an old question. Like I said, this year NEET PG had lots and lots of repeats. Not from the last 3 years, it had from the last 7 years. This is one of the questions from, I think, from 2013-14 aims. So I'm making it a thing that we will definitely read all the repeats from the past 10 years, at least with respect to pathology, in the next 2 months before your INICET, fine? It's a 10-year-old kid, dermatology OPD. There's a classical finding. You can see these inclusions. Molluscum produces intracytoplasmic eosinophilic inclusions, right? These are characteristic intracytoplasmic eosinophilic inclusions, right? Characteristic intracytoplasmic eosinophilic inclusions, which are diagnostic of molluscum contagiosum. And if you look at it, molluscum most of the time produces inclusion bodies in the stratum granulosum, more over the stratum granulosum, very less in the basal layer, and maybe in the spinosum, right? It's predominantly in stratum granulosum, which where the inclusion is very, very common here, fine? Okay, fine. If it's a photo of individual, I think umbilicated nodules should be more than enough. I think Jasir will talk more about umbilicated nodules in dermatology. It's a classical case of molluscum contagiosum. Fine. If it's photo of a clinical patient, I will remove this from my slide. Okay, because I also want to push away molluscum to someone else. Fine. Great. Okay, this was the question. Anushya, Warthin-Filkenle was mentioned in the microscopy of the same question, or there's another question with Koplik spots. That question. I think it was one for the Koplik spots and the measles, right? This was a different one. That was a different one, if I'm right. Okay. This question, there are two of them asked a very, very logical question, like why it is not an adenomatous polyp. This is a very simple question, right? It's a 5-year-old person with altered bowel habits and blood in the stools. Rectal mucosa showed a polyp. Microscopy shows dilated glands filled with mucin. What's the most likely diagnosis? The diagnosis here should have been made with this 5-year-old. 5-year-old, I have only one guy, which is juvenile polyp. Okay. Only one person who is a juvenile polyp, right? So juvenile polyp is definitely the most common hematomatous polyp. My question is, quite a few of them asked why it is not an adenomatous polyp. See, because in pute sugar also we use the term hematoma, right? We don't call it adenomatous, we call it an hematomatous polyp. Why I'm not using the term adenoma and why I'm still sticking with the term hematoma, right? We'll take this part alone, not going to pute sugar. I'll tell you why I'm still sticking to the hematomas and not the adenomas, fine? Okay, Mithu, taken. So let's say if you have a juvenile polyp, so juvenile polyps, the sporadic juvenile polyps, I'm not going to the syndromic ones, the sporadic juvenile polyps. The reason is, let's assume these are the glands. All these glands of the rectal mucosa are exocrine glands, right? They have glands here and they'll automatically have ducts joining, and that's how they're going to secrete all the contents, right? So what happens here in kids who are constipated for a long time, the constipated or the hard impacted stool will hit the rectal mucosa will cause damage to the rectal mucosa. So what happens is they're going to block them. Once it damages rectal mucosa, the fibrosis, the healing related fibrosis will block the ducts. So when something blocks the ducts, right, this is a pathogen of a sporadic juvenile polyp, right? Is there a possibility the mucin cannot be secreted outside? The glands will synthesize mucin because there is no problem in mucin, but they cannot secrete outside. So because of this reason, what happens is the glands which are obstructed, the duct obstruction, those guys becomes huge. Rest of them will still be normal because there's no duct obstruction there, right? Just to make it much more sense, this is what happens here. So if this is the problem happening in your juvenile polyp, now tell me, is it a neoplastic proliferation or an inflammation related condition? Can I call it adenoma or not? Because generally the term adenoma is useful for neoplastic proliferation, right? Here, is it a neoplastic proliferation or just because of obstruction and mucin accumulation, it looks huge? It's just due to the obstruction. There's no neoplastic proliferation here. This grossly looks like a polyp because a huge dilated gland, imagine like a huge balloon, right? Very huge dilated gland, that's why it results in a polyp. Now there's no proliferation here, so it is not adenomatous. Okay? It's not an adenomatous polyp at all. It's a juvenile polyp. Juvenile polyp is hematomatous polyp, fine? I will use the term adenoma. Whenever I use the term adenoma, I always have a even slight risk of a neoplastic transformation. Juvenile polyp doesn't have the risk at all. It's just a polypoidal projection without any risk of neoplastic transformation, and it is not neoplastic, so it is not an adenomatous polyp, right? It's an hematomatous polyp only. The same way we have inflammatory polyps. Chronic gastritis, H. pylori related. I can have polypoidal projection. In inflammatory bowel disease, we have the pseudopolyps, right? All these are inflammation related thing. I will not call it adenomatous because I don't have a neoplastic proliferation there, right? That's the reason I don't call something as adenomatous. We still keep it to a hematomatous polyp, fine? The classical, this also was a repeat, I think from 2019 NEET exam or 18 NEET exam. It's exact repeat. In that exam, there's an image also given. I am not sure if the image was given in this question, right? It's a very classical finding. Please don't miss these. I don't want you guys to miss on repeat questions because that's where you tend to make a mistake, right? Because that's not good. You tend to make a mistake when you miss on repeat questions, right? Please don't do that. Okay? This was one more question which is extremely controversial, right? Uh, Parkinson's or prions is a problem because I'm sure everyone must have read the question multiple times. Okay, 73-year-old is not having the exact symptom list of Parkinson's because quite a few of them said visual hallucinations was there. Hallucination is not a classical finding seen in Parkinson's. I'm sure you guys will accept. The rigidity, slowness, everything. Staring at sky, that's also was one of the features in the question. That might be a classical finding seen in Parkinson, right? This is something which is an outlier. But I had this also, right? Lewy body. You guys know that whenever you see Lewy body in a question, the first you think of Parkinson's, you think of multisystemic atrophy or Lewy body dementia. These are the three things. And one more disease called as Scheidegger syndrome. You can think about that alone, right? So when you have Lewy body, okay, the Lewy body is diagnostic of only few disorder. But here I have a Lewy body with a history not suggestive of Parkinson. Among these four options, only one can have Lewy body, which is Parkinson's. Other cannot have Lewy body. I might have pink inclusion in prions. I don't call it Lewy body. Alzheimer's also will have inclusion. Huntington's also will have inclusion. But those inclusions are not termed as Lewy body. That's the only difference. All these are protein accumulation disorders only, but I don't call them Lewy body, right? But again, Alzheimer's, your visual hallucination might not be a perfect match for Alzheimer's also, right? Huntington's chorea not a perfect match. Prions might have, fine. Okay, coming to questions of Anushya, right? So this history, along with the finding of Lewy body, will be a perfect match for Lewy body dementia. That will be a perfect match because Lewy body dementia can have hallucinations, can have the progression, can have everything, and can lead to death as well. Maybe one possibility is examiner must have missed this. Right? Possible examiner must have missed that in the options instead of putting Lewy body dementia just to confuse you guys left with Parkinson's. If this was the exact recall with the history, confusing history, and Lewy body mentioned, don't worry. Last NEET exam, if you remember, NB released a statement that two questions were not right, and it's everyone will be awarded marks. I hope this time also NB will announce it because it's not a perfect question. If this was the exact question, it's an incomplete question, and the best option, the closest option has to be Parkinson's because other things cannot have Lewy body. The only thing which can have Lewy body is Parkinson, but hallucination is a very extremely rare or an impossible symptom for Parkinson's, fine. Okay. I discussed with Rahul, he's a neurologist, and he also was aligned that it will not exactly fit in the microscopic finding as well as the clinical picture in this image, fine. Okay, next. That's a very simple one. See, we read about paraneoplastic syndromes in your sprint as well, right? In the sprint series, we did see this hypercalcemia and a lung tumor. There has to be only 1% squamous cell carcinoma. There's nothing else here. It's not an adenocarcinoma. It's not small cell. Small cell can be related to smoking. Small cell can also have paraneoplastic syndrome, but small cell will have the other paraneoplastic syndrome, like your Cushing's or your SAADH. If you have the same question with some other feature, SAADH or Cushing's, yes, I might think of a small cell carcinoma, but never if it's in hypercalcemia. Hypercalcemia, PTH related peptides, it's diagnostic of your squamous cell carcinoma only. Fine. Okay. I'm not sure about the age here. I just put a random age in this question. 20-year-old person present with retroperitoneal hematomas, recurrent history of swelling in the knee. This means I'm dealing with a coagulation disorder, right? It was a male patient, if I'm right, fine. Coagulation disorder, deep-seated bleeding, hemarthrosis. Whenever you have hemarthrosis, deep-seated bleeding, my first possibility is going to be hemophilias. A or B, anything it can be. I can prove whether it's A or B only based on further investigations, right? So the best bet for me here is 8 or 9. Factor 10 might not have the exact finding. Factor 12 will most of the time be asymptomatic, will not have it. Von Willebrand deficiency, yes, the type C. The type C von Willebrand deficiency can have the type C or type 3 von Willebrand disease, can have the classical finding as above, but type 3 is very, very rare. Type 3 is zero amount of von Willebrand, which is almost equivalent to your hemophilia, right? So the best answer here clinically without any information. I need PT, APTT, factor ICA to come to a diagnosis. Clinical diagnosis, I'm going to go for factor 8 or factor 9 deficiencies most probably, fine. Okay. Okay, this was also a question that it's again the question is from your recall. I had put multiple images in the Telegram group that some of the students or quite a few students said that the image looked something like this. There were confusions whether it can be rheumatic heart disease or not, Chagas disease or not, or lymphocytic pericarditis, myocarditis. This was anyway out of the thing, right? This was the image which quite a few students said it looked like that image in the exam, right? I want your guys' opinion that if it's like this, small round blue cells in the myocardium, then I'm going to go for lymphocytic myocarditis because that is one of the commonest type of myocarditis. Lymphocytic, any viral induce can trigger lymphocytic myocarditis, right? Chagas disease will have an inclusion, will have a parasitic inclusion. If you have this, you'll have multiple tiny dots inside the myocyte. If it's not there, very, very unlikely to be Chagas. Giant cell, you'll have giant cells anyway. Next is rheumatic heart disease, right? RHD, there are quite a few things which are against for me for RHD, right? Acute rheumatic fever. Acute rheumatic fever or rheumatic heart disease, fine. There are quite a few things which are for me against for an RFD. If it's an acute rheumatic fever, like Piyush said, I should have had a history of throat pain. Sore throat should have been there because RHD or acute rheumatic fever is diagnosed based on your Jones criteria. I'm not going to diagnose based on the myocardial biopsies, right? First of all, doing myocardial biopsy is very unlikely. Again, I don't have a classical history one. Next, yeah, rheumatic heart disease or acute rheumatic fever. Right. Next, ventricular tachycardia and dysfunction is not the primary presentation for a rheumatic heart disease. Acute rheumatic fever or rheumatic heart disease, I'm sure you'll accept. It's valvular pathology, can be pancreatitis, but ventricular tachycardia and dysfunction, very, very unlikely for it. But on the other hand, when it's myocarditis, when the entire myocardium is gone, I might have arrhythmias as a mode of presentation, right? The only thing why I'm not going for rheumatic fever is one, I trust you guys. If it's Ashoff, you would never had a doubt because you have seen Ashoff plenty of times, right? If it's Ashoff, you know it's Ashoff. If you're thinking it's whether it's an Ashoff, it is not Ashoff because Ashoff body is something which you've seen continuously again and again. Okay, Ajay, if it is central lymphocytes and peripheral, I don't have lymphocyte, doesn't matter. It's lymphocytic carditis, right? Because I'm preferring more towards lymphocytic carditis for the only reason I don't have the classical history of rheumatic fever. Rheumatic fever should have a classical history, which is not there. I cannot diagnose rheumatic fever without a history. Ashoff body alone is not diagnostic for me for rheumatic fever. Though it's pathognomonic finding, I need the criterias. And in the criteria of acute rheumatic fever, you never had a biopsy finding at all. It's a finding scene, that's all right. Since there's no history and tachycardia and dysfunction is not the sole presentation of acute rheumatic fever, I'm not going with rheumatic heart disease or rheumatic fever. Chagas is not there because Chagas will have inclusion bodies inside the myocardium, which is not the seen. So the best bet would be lymphocytic myocarditis, right? Again, like I said, I'm taking your inputs and trying to solve it. Might be right, might be wrong. Fine. If I hope in future NB will release the answer key so that we'll have a correct answer. Fine. Okay. This again. How many of you guys wrote in this hereditary spherocytosis and osmotic fragility test? You can tell yes or no, and later on, if you feel bad, you can delete the comment. That's completely fine. If you have answered hereditary spherocytosis and osmotic fragility test for this, please give a nice knock on your head, because this is one of the things which has been discussed plenty of times, right? Whenever you see spherocytes, do not jump into spherocytosis. That's the first thing. We have taught this multiple times, right? You shouldn't make a mistake here. Fine. Please don't make a mistake here. Please don't make mistakes in these. I know it's very tempting to go to HS, but please don't make a mistakes. Right? If it's spherocytosis, see, it's very simple. Remember this. I'm having spherocytes, right? I'm sure that everyone here knows that there are multiple differential diagnoses of spherocyte. One is obviously HS. The other one is obviously autoimmune hemolytic anemia. Am I right in saying that I will see spherocytes also in G6PD deficiency? I will. And see spherocytes in multiple disorders, right? But these are the common ones. Any organ system, not just hematology, any organ system, which is more common, acquired or inherited? Which disease is more common? Undoubtedly acquired, right? Undoubtedly acquired is more common, so undoubtedly I'm going to think of AIHA only, because autoimmune hemolytic anemia undoubtedly is the most common cause of spherocytosis. We have discussed this multiple times. Whenever I see spherocytes in peripheral smear, I'm going to go for your AIHA and Coombs test and never HS and osmotic fragility test. And if you listen to me in the sprint as well, it's a very useless test. I don't go for that at all. HS, if I have to suspect HS, I go for flow cytometry, right? Please remember this. Any point of time in your real life or in any question which you're going to attend in future, acquired is way more common than inherited disorder. Acquired disorder is way more common than inherited disorders. Please don't make this mistake, right? Because these are very basic things which I don't want you guys to make a mistake. Fine. Okay, which is fine if you made a mistake. Hopefully in the next sessions, if something simple like this comes in your INICET, don't make this error. Write it correctly, right? This paper was a very simple paper. So our goal, hopefully the same will be repeated in the INICET. You had close to 40-50% of the paper repeats. So if that's the goal, we'll do all the repeats in the last 10 years. Doing the last 3-4 years must have been a problem, because they have asked 2012 2013 questions as well again here. Fine. Next, it's a very simple question. Don't overcomplicate, because I have one classical clue here. The clue for me here is not the person working there. Piyush, age doesn't matter, because autoimmune disorders can be seen in any age group, though the most common is middle age group, right? Again, even if it's hereditary spherocytosis, it's an autosomal dominant disorder, right? Autosomal dominant disorder will be presenting in later half of the life only, not at birth, right? Be it autoimmune or autosomal dominant, the age group is more or less the same. So age will not matter for me, right? Okay. So the classical clue here is mesothelioma. The patient had mesothelioma. If there's a patient had mesothelioma, which is a very unlikely thing, I have only one diagnosis, which is asbestosis. Silicosis, coal, or iron oxide, which just I added to make it 4 options, will never cause mesothelioma. I'm sure this also is a very frequently repeated one, right? Most common is adenocarcinoma, most specific is mesothelioma. You will never forget till you have your life, right? Mesothelioma, you're going to go for asbestosis. That's it. Spike and dome. So this also is a repeat one. Spike and dome appearance is one of the characteristic features seen in membranous glomerulonephritis. I'll try to explain what is spike and dome, and we look in the microscopy as well, right? Can anyone help me with the etiopathogenesis of membranous glomerulonephritis? The antibody is produced against which antigen? If you remember, it's produced against the antigen called as PLA2R, right? Phospholipase A2 receptor. That's the antibody which is produced against in case of membranous glomerulonephritis, right? Let's take a normal glomerular membrane. Let's assume this is a normal glomerulus, the capillary loop. The PLA2R are like this. That's why the PLA2R are, the black lines are the PLA2R. Let's assume I'm having an antibody. So disease, the antibody binds like this. I'm putting pink dots because antibodies are pink color, right? Okay. When I'm having antigen antibody reaction, it destroys the capillary wall, and I'm going to have the disease nephrotic syndrome. Fine. So when I'm going to do a silver stain, To this, I'm doing a silver stain. Silver highlights anything which is thin, right? You know that. That's why you use Warthin-Starry, we use Steiner silver and everything for thin structures, right? Here, what happens is silver highlights the basement membrane. So what happens is the silver will highlight the basement membrane like this, and in between the basement membrane, the immune deposits. The immune deposits will not be highlighted. That's getting deposited, it will not be highlighted. I'll come to it, Dipanshu, just give me a second, right? It will not be highlighted here. Since the immune deposits are negative for silver, okay, and the basement membrane is positive for silver, it kind of looks like a spike and a dome, right? That's why it's called as a spike and dome appearance. It's just again because of the pathogenesis. The silver stain used for, maybe if they ask in future, you have to know this. In renal biopsy, I use a staining technique called the Jones stain, which is the basic for silver stain, right? Dipanshu, coming to a question, the rheumatic fever, like I said, it's not just my heart. Rheumatic fever, if you look at the Jones criteria, which you guys will never forget, it's everything, right? I don't have a history of joint pain. I hope it is not there in the question. There's neither subcutaneous nodules, there's nothing there. Without that, just by looking at a myocardial biopsy, jumping into rheumatic fever is a very bit of a stretch. And that's why I'm preferring lymphocytic carditis. Like I said again, I trust you guys, you will never forget or miss an astro body. That's one more thing saying that okay, it's most likely in lymphocytic carditis, fine. Okay, this what's the reason for a spike and dome. I'll show a spike and dome in a real image. Can you see the tiny projections here, right? These tiny projections here are the spike and dome. You can see the arrow marks, tiny projections. In between there are empty spaces. In the empty space where I have the antibody deposition here like this. That's what happens in membranous glomerulonephritis. It's a classical spike and dome appearance of a membranous glomerulonephritis, right? So now not just that we know the finding, we also know the reason why I have the spike and dome in membranous glomerulonephritis. Clear? Fine. Great. I hope your doubt is sorted, Dipanshu. This question again is a huge problem for us, right? I want just one question before going to the discussion. Was it mentioned electron microscopy? So this is very important for me in order to go to it, fine. Ajay, great. Thank you for the input. If the person is HBsA positive, hepatitis can cause MPGN, hepatitis can cause MGN. So again, spike and dome doesn't change. The answer remains the same. It's membranous glomerulonephritis only. Fine. Thank you for the input, Ajay. Was there electron microscopy in this question? Because that changes lots of things for me. If the question was, did have electron microscopic image, then I'm going to go for subepithelial deposit only. Because crescent is a light microscopic finding. I don't want an electron microscopy to look for crescent, because crescent is electron microscopy. I'm going to magnify a lot. I will not be able to look at the entire crescent in electron microscopy. So it's a light microscopic finding. Though there is a history that it went up to 4.5 and there was 3 weeks. There's no electron microscopy in the question. Then I am confused because quite a few students said that electron microscopy was there. So it changes a lot. I'll give you both the options, both the possibility, right? So this pyoderma, after that, the patient had an nephritic syndrome, hematuria, and a creatinine levels, the classical case of a PSGN. So what the question says is, the patient had PSGN, over the period of next 3 weeks, the patient's creatinine shoots up. Creatinine becomes 4.5 milligram percentage, which is a spike, right? Because what happens is every PSGN is self-limiting. Once the sore throat goes away, this damage automatically will settle within 3 weeks. So if PSGN is having elevation of creatinine or hematuria or any other kidney problem, even after 3 weeks, which means there is a super added disease. It's not just PSGN. There are multiple possibilities. One of the possibilities is it can go to RPGN. Okay, can go to an rapidly progressive glomerulonephritis. Again, keeping in mind 4.5 is a spike, definitely is a spike, and if it's a sudden spike, yes, definitely matters. It might be an RPGN, right? Now here, RPGN in light microscopy will have crescents. RPGN for me in electron microscopy, to say it's RPGN, it's not about the deposit. To say it's RPGN, my diagnostic finding is break in the basement membrane. I'm sure you must have heard this, right? We had an PYQ also based on that. You have a classical elevation of it with a break in the basement membrane, right? That's diagnostic electron microscopy of RPGN. Was this there in the option? If this was there in the option, I would definitely prefer to think about that. If it's not there, Like I said, crescent is a light microscopic finding. I'm not going to look, see, because to look at a crescent, I need to look at the entire glomeruli. That's how a crescent will look, right? But what I do in electron microscopy is I look at this. I look at the endothelium, the epithelium, the food process, right? I cannot look at a crescent in a light microscopy, fine? If the question had electron microscopic image, the only thing I can say here with the history is, though it's an RPGN, it's 3 weeks old PSGN, right? So I will definitely have the electron microscopic finding of PSGN also in this patient. And the electron microscopic finding for PSGN is subepithelial deposit, right? It has progressed to another disease, but still I'll have the primary disease finding here for sure because it's a very narrow thing, right? Since electron microscopy was there, I would prefer a subendothelial deposit, subepithelial deposit, because this is a finding seen in PSGN, which is the primary disease here. RPGN is a complication. RPGN is a complication. It's not the primary disease. Let's assume I'm having a patient with Goodpasture syndrome. Goodpasture syndrome can also go to RPGN. In Goodpasture syndrome, whatever finding was there will be there in RPGN also. Lupus can also go to RPGN. The full house effect will still be there even if it's RPGN. So those are the primary disease. The primary disease finding will definitely be there. Since I didn't have break-in basement membrane, I'm preferring a subepithelial deposit. Again, if there was a break-in basement membrane in the question, then that should be the appropriate answer because we had a PYQ of break-in basement membrane, right? So this changes everything. If it's electron microscopy, I'm going to go to subepithelial deposit only. Fine. I hope that's clear. Okay, this again, there are two things here. Option C and D, whatever you're given, is it right or wrong? Because I'll tell you what exactly happens in Graves' disease, and then we can go to say which is the right option. Graves, what Robbins as well as Harrison says is, Graves will have antibodies against thyroid TSH receptor. That's how Graves is, right? In Graves, I'm going to have antibodies against TSH receptor. Robbins as well as Harrison clearly says that this antibody can be either stimulating or it can be destroying. Then I'm going to have thyroid stimulating immunoglobulin, which is seen in more than 90% of the patients with Graves, and is very, very specific for Graves because I don't have any overlap. I don't see this in any other disease, not like ANA. Anti-nuclear antibody I can see in multiple diseases, right? I won't see this in any other disease. So thyroid stimulating immunoglobulin is very characteristic, or a long-acting thyroid stimulator, right? It's very, very characteristic of Graves' disease. But it's also said that I might have approximately 5 to 10% of the patient who can have TSH destroying antibodies as well. Okay? In those conditions, Graves might not have classical hyperthyroidism, it might have a hyper and hypo, right? So it based on the options. If it's antibody to TSH receptor was the only option available and this was not there, I can go to antibodies against TSH receptor because TSI, thyroid stimulating immunoglobulin, is nothing but antibody produced against a TSH receptor which goes and binds to them and does the function of TSH. So it kind of results in an hyperthyroidism, right? So it's based on what the option is. If this is the question, both of them are right. I would prefer thyroid stimulating immunoglobulin as a diagnostic point because it's not seen in any other condition. I might see antibodies against TSH in some other condition, but TSI is never ever seen in any other condition apart from Graves. It's like unique. I can call it pathognomonic. This is seen only in Graves. So any patient having TSI levels elevated, so that's fine. Anti-thyroglobulin, then that's not the answer. If this is not thyroid stimulating antibody, and if it's anti-thyroglobulin, if this was option C, like what Anupriya, right? Anupriya said, then my answer will be antibodies to TSH receptor, fine. Okay, if it's TSI, then that's the answer. If it is not TSI, only antibodies to thyroglobulin, then I would prefer to be an antibodies to TSH receptor, fine. Okay, I hope it's clear. Anti-TPO antibodies obviously it is in Hashimoto's thyroiditis. We are not going to get confused with that, fine. Okay, next. It was a simple question, right? 36-year-old person, a prisoner with fatigue and found to have 4.5 grams of hemoglobin and given transfusion of 4 units in 6 hours. That kind of goes towards a massive transfusion. They are pumping the transfusion very fast. Very fast transfusion is automatically a risk for TACO. Transfusion associated circulatory overload. I don't have TACO in the options like you guys said, but I do have fluid overload. Fluid overload will definitely cause bilateral crepitations, can cause pulmonary edema, which can cause bilateral crepitations, right? It's a very simple question. Last year, we had TACO trolley they make sure that at least one question comes from your exams, like from your transfusion medicine, because transfusion medicine is important for an intern. It's very, very important for a practicing doctor. So we need that. Okay. Okay. Then if anti-thyroglobulin was there in the option, the last one, then antibodies to TH receptor is the right answer. It will be option D only. Fine. Okay. They've included quite a few questions which is there in the exam. I wanted to keep it short, like I said. We will cut it off here. I know that you might be in a space now knowing what to do, right? Do you want to prepare for NICT or not? I would say your counseling is not going to happen very soon. So go with the same tempo, try the NICT. Who knows, you might get a rank in good rank in INICT and you will join your AIMS or GMR or PJ Chandigarh even before your NEET counseling commences, right? Because thanks to our NMC, they have made such a very bad structure which is going to spoil all of us. So maybe take a 1 or 2 day gap. It's good enough now. Start reading at the earliest. Start from very basic topics which you like. Like I said, I have the both WhatsApp group as well as Telegram group. I'll make sure we do all the previous year questions starting from 2012. We'll do last 10-year questions of AIMS, GMR and PJ. So we make sure we don't miss anything which is a repeat. Because the take-home message from this paper is they have gone to older repeats. It was a paper which is very, very easy, full of old exam repeats. I'll make sure we'll do it at any point, right? There's no stones, we'll leave no stones unturned. We'll definitely do all the PYQs in the last 10 years. With respect to pathology, I can promise you I'll complete that before the May exam. We'll do it by this month and next month. By April end, we'll have to complete all the 10 years PYQ and definitely we'll do it. You guys will do well in your INICT. Fine. Thank you, Anmol. Good evening, Anmol. And thank you guys for your time. I'm signing off here. So if you have any questions, any doubt, do ping me in the Telegram channel or in Instagram or in the WhatsApp. If I don't reply, ping me again. I'll definitely reply. Fine. And whatever questions I post, be active. Answer it's fine. Because only when you make a mistake, you won't repeat it again, right? You must have made a mistake in NEET exam. I can promise you and tell you, you will never ever forget the mistake. Because mistakes make permanent memory circuits, and hopefully you'll make mistakes before the exam and not in the exam. Fine. So thank you for your time. I'm signing off. Bye bye. See you soon. Okay. And for all the UG students who are watching here, PW will have both live batches as well as recorded batches. We'll come up with a